on this episode of A Tale of Two Hygienists.
I assess a suck on every baby I see. And I think this is another piece that we miss even in the hospital world. People will say, oh, no one ever put their fingers in my baby's mouth. And that blows my mind because a proper newborn suck is so specific. When you have felt normal newborn suck patterns and then you feel something that isn't normal, you know right away that something's going on here.
You know, it's never okay for our child or baby to not get enough oxygen. So I think parents, need to understand that it doesn't matter how much your baby sleeps. It doesn't matter how much your child sleeps. If they're not getting the correct sleep cycles, if they're not getting enough oxygen, it is going to impact that baby's well-being.
Artificial nipples are not the enemy and they do not break babies. Babies do not get nipple confusion. That is not real. They are way too smart to get confused. They know exactly what they're doing.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Well, hello there. Thank you for listening. That just sounds so wrong. Never mind, everyone. I was going to try and change the beginning of these episodes. I feel like sometimes, you turn on the show and then it's like me saying exactly the same thing every time. Might be a little bit repetitive. So never mind. Let's just start again. Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 422. I'm your host, Andrew Johnston, and thank you so much for making us a part of your day. Yeah. That feels a lot better. Okay, let's get into this episode. And I'm going to keep this intro really, really short because we're jumping right back into the conversation that we started last week with Heidi, Leslie, and Paula about myofunctional therapy in babies. Some really, really good tips and tricks, some methods. And I can't stress this enough. If you are interested at all in this realm, if you like what you're hearing, if maybe what Heidi is saying is kind of more along the lines of what you want to do, or Leslie, or even some of their guests they have on over this week and then the next couple of weeks, make sure that you're reaching out. I have put their contact information in the show notes along with Paula's. So don't wait. Make sure you reach out to them right away. And I probably should have asked them this because I didn't get their permission. I don't think they'll really care, but you just never know these days. But Heidi and Leslie will both be at Chicago Midwinter here in 2 weeks, from what I understand. So if you are planning to be there, or if you're in that vicinity and you can just make it there even for the day, please reach out to them and set up a meeting, because they are smart, they're engaging, they're fun. It's going to be absolutely worth getting to know them and seeing where they can help you or you can help them, or there's some sort of synergy there. I don't have any other news for you as I continue to cry about my Niners losing the Super Bowl. So I will just go do that while you guys listen to this episode. So let's jump back into the conversation with Paula, Heidi, and Leslie.
A tale of two hygienists.
Paula, I want to talk about when you are assessing a family and what kind of things lead to you then maybe recommending when I do an evaluation for tongue tie and other oral tether tissues.
Yes. One of the things I loved about meeting your team initially was how much crossover we had in our intake forms. So many of the same questions, which made me really understand I was in the right place. So the big red flags are pain with feeding. So if I have a family who has substantial pain or damage, the damage blows my mind because I don't even know how those families are still breastfeeding that way. But substantial pain or damage, and then slow weight gain, those are the big ones. But usually they're checking 6 or 7 boxes. So they also have, they're leaking at the breast or with a bottle. They're choking, gagging, spitting up constantly. They often have really substantial reflux symptoms. Or we have those long sleepy feeds, short feeds where they want to feed constantly. What else? Lots of hiccups is an interesting one that we see all the time. And just feeling like something isn't quite right. Low supply is on the list. I'm trying to think of what else. Leslie, what other ones are on your checklist?
Of course, now I'm trying to think. I feel like you listed a majority of them. I know It's, like I said, the falling asleep, the shallow latch, the popping on and off, the frequency of hiccups. We even ask if hiccups happened in utero because, again, the swallow starts at 20 weeks in utero. So sometimes this is something that's already been kind of occurring even in utero. And I feel like there's also sleep questions. So a lot of times, again, tongue posture can actually be related to some of the reflexy symptoms, which can also, kind of correlate to sleep. So when there's the inability to really breathe through their nose and they have to be mouth breathing and there's audible breathing or even snoring happening in their sleep, the restless sleep, sleeping for those really short intervals where they, same thing, are waking frequently. So we do have some sleep questions on there too. And then I feel like it's the ones that you had mentioned there too, Paula.
Sleeping with their mouth open. Like newborns shouldn't sleep with their mouth open. When I go back and look through photos of my fifth baby, every sleeping photo, that baby's the chin is way up in the air and the mouth is all the way open, and he still sleeps like that. So we're working on it. We're working on it. But yeah, and I think these are pieces, again, why are they related to feeding? Nobody can really understand unless you have this additional education. And then I assess a suck on every baby I see. And I think this is another piece that we miss, even in the hospital world. People will say, oh, no one ever put their fingers in my baby's mouth. And that blows my mind because a proper newborn suck is so specific because that tongue has to come forward and then it kind of undulates, right? Whereas babies who are tethered or even just have tightness initially, they kind of flick or they move back and forth. When you have felt normal newborn suck patterns and then you feel something that isn't normal, you know right away that something's going on here. And sometimes it is just tightness for sure, or like weak suck, no vacuum, I can pull my finger right out instantly. Can they keep a pacifier in their mouth is another question.
Yes, that is one of the questions. You're right.
Gag reflexes, right? Because those babies like a shallow latch. They don't want anything in the back of their mouth. And that's where the nipple is actually supposed to rest. And they will pull themselves right back or gag when anything touches the soft palate. So yeah, those are the big ones. And, we typically send them for body work first. We've got this really amazing system here where I will actually fax my notes, if I remember, to Leslie and her team. And then they'll do sort of a same assessment. And there are times when I am wrong. And this is why I love that we don't work in the same building and that our money isn't going to the same place. Because it's like we're checking, we have checks on each other so that we're being very cautious and only releasing babies who need to be released. And so they will sometimes assess and say, no, we need to see X, Y, and Z first, or we don't see this being the biggest problem. And even then, we get to rule it out and keep moving forward, or like, let's try 3 more things. And if we're not getting to where we want to be, we're going to send you back, to this office and have the myofunctional therapist look again and update them on what we've seen in the meantime.
What's the time frame on that real quick? So like before, like, do you do like 2 weeks worth of stuff, then send it over to Leslie?
Depends on the baby and the situation. If it's nipple damage, we usually move a little bit faster because those families will be done breastfeeding. They won't make it. And what I love about Leslie and our team is that they're quick. We can usually book them very quickly, or they'll put them on a cancellation list. If it's more weight gain, we have a lot more time. If it's like weight gain issues, because there's other ways to feed a baby in the meantime. And so often, yes, 2 weeks. I don't love releasing babies in their first 2 weeks of life just because we have a lot more we need to understand. But typically I would say, yeah, like it's about 2 weeks of let's try all these things, see what type of improvement we see. And then if we don't see the changes we want to see, we're going to send you over, to have this additional assessment done with the myofunctional therapist and the dentist.
I just want to point out one thing too, that I think it's really important, to point out to parents and stuff too, that mouth being open, that heavy breathing, snoring. It's never okay to hear that in a baby or a child. Their lips should always be closed. The tongue should always be up. And this was one thing I think I mentioned on our first session, Andrew, is why I kind of went down the road with, myofunctional therapy and became so passionate about it, because I was at a pediatric airway course back over 10 years ago, and my daughter was a couple years old at the time. And I'm checklisting all these things that he's telling us to look for, and he said something very profound. He's like, how often is it okay for your child to not get enough oxygen at nighttime? Because that is essentially what is happening. If that mouth is open, that tongue most likely is, not going to be in a proper position, softly glued to the roof of the mouth. And it's going to obstruct the child or baby's airway, causing a heavier breathing or snoring. And that, to me is like, it's never okay for a child or baby to not get enough oxygen. So I think parents, need to understand that it doesn't matter how much your baby sleeps. It doesn't matter how much your child sleeps. If they're not getting the correct sleep cycles, they're not getting enough oxygen, it is going to impact that baby's well-being. So,
yeah. It's also kind of hilarious how many times I have both parents in my office and I'm like, which one of you sleeps with you now?
Yeah.
And I had a dad here last week who was like, started the nasal spray and I'm going to start, I read breath. And I'm like, you're welcome. You didn't know you were getting all of that in the lecture.
Yeah, we always blame dad usually when we're in the office. Mom's already dealing with enough. So we're like, Dad, this is your fault. But not always is that the case. But yes, looking at mom and dad, and even that's another question too. If this is a second or third or however, child, sibling, we ask, did the first have any type of ties or issues with feeding too? Because it, there is that component to it. But to kind of circle around to kind of piece some of these things together too. So once Paula kind of refers them and we're looking, and same thing, the same type of questionnaires and looking at the suck and feeling how that suck feels around that finger and what's actually happening with the swallow. I think, and Paula will agree, is that a lot of times, same thing, these families have maybe seen multiple different providers at that point, and they can be being told multiple different opinions towards things. Like you can see 5 different providers and have 5 different opinions on what's going on with your baby. And so they come in very overwhelmed and like, and I just feel for them because same thing, I've been in this position, but I try to explain to them what we do want the mechanics of the tongue to be doing. And also when they're like, well, the pediatrician or so-and-so, it's not always the pediatrician, but somebody said they can stick their tongue out, so they're not tongue-tied. And my response to that is there is no part of feeding that we need to stick our tongue out for. So like that does not matter to me. Like I don't need them to stick their tongue out beyond their lip necessarily to be doing the feeding. And what people don't understand is that, and again, like Paula was kind of mentioning, is sometimes when we feel the suck, it's the tip of the tongue doing all this work. And it's because the back of the tongue is actually what's more restricted. And really we want a tip of a tongue that can kind of almost create like a cupping and a seal around that breast. And then the back of the tongue can drop down, draw the milk in, and then we want a back of the tongue that it can actually elevate. It needs to be able to lift up off of the floor of the mouth, going up towards the palate. And that's what creates that undulation motion. And so when we check for ties, it's not just can a baby stick their tongue out, it's can a baby elevate their tongue off of the floor of their mouth. Because if a baby can't properly elevate that back of their tongue off the floor of their mouth, well, they are going to adapt usually. A lot of these babies have figured out the compensation and the adaptation, but it's by engaging, like we were kind of mentioning, the jaw or the lips are super tight and the jaw's clamping that down. And that's why poor mom's nipples are being so damaged, is because that's just so tight there. So kind of going through and explaining that to our parents, like the mechanics of what we want to see is really that back of the tongue. So when we do an assessment for it, not only am I feeling the suck and how that feels to make sure that there's actually kind of proper muscle engagement, but then when you do an evaluation, you're actually going in and lifting the middle portion of the tongue to go up, like almost like a forklift. I kind of explain it when I go into these parents, like you're lifting up so that you can see how, if there's tension to the way that band of tissue, which again, we all have that band of tissue, it's a normal piece of anatomy, but how it actually looks underneath the tongue. And does that whole floor of the mouth lift up with it? Do the salivary glands have to lift up over the ridge of the gum in order to lift the tongue up? Is it attached to the inside of the alveolar ridge? Is it attached to the floor of the mouth? There's all these, things that we kind of look at with that to see what's happening here for the baby. Like Paula had mentioned, the palate. A lot of people don't realize when the palate is mentioned that if we feel a very narrow palate, that can tell us that the tongue's not really going up there, because if the tongue was going up to the palate and a baby who's developing, that palate would be creating more of the shape of the tongue, not this very narrow vaulted palate already. So that's already an indicator that from in utero, something's, been shifted there.
Is there ever a situation where you're not getting that back of the tongue movement that you want that's not related to a tie, or is it like tie for sure?
I think sometimes there is. Yeah. I think, I've seen babies come out who are tongue thrusters, and they've been sucking in utero the way they've been sucking for all. And so sometimes we can do suck training with babies and it changes the whole function of their tongues. I've seen babies tied to the tip. I've seen anterior ties to the tip of their tongue and they feed beautifully. And it's, kind of mind blowing that this is why it's so nuanced and why people can't be diagnosing via photos over Facebook. It's so nuanced of how the function and the anatomy, it's not one or the other. It's absolutely both. And let's try 75 things before we go in a baby's mouth with a laser. And I think that's one of the pieces. I mean, we could talk about the New York Times article forever. That's one of the pieces that is frustrating to me, is that there's an idea that we're just cut that tongue, cut that tongue, cut their tongue. And we are so far from that we're looking at each individual dyad and how the tongue is functioning along with the structure of the tongue.
Okay, I want to talk about suck training before we get to this New York Times article. Because that, you piqued my interest now. Actually, now that I said it, I think I've actually seen it. Anyways, so suck training, because it's hard enough getting a teenager to comply with things, even harder to get a child. How do you train a baby to do the thing, and what does that kind of time frame look like? Having a real expectation for parents out there.
Yeah. Oh my gosh. So something you should know. So I'm mom of 5. I am the most realistic human being. I have a really strong understanding of what parents can handle and what they can't. And everything that we talk about is here's what would happen in a rainbows and unicorns scenario. And then you're going to do what you can do, right? And if you get these exercises in 4 times a day, you have ice cream before you go to bed because hurrah, you did it. It's so hard just to feed yourself and feed your baby in those first few weeks. So basic suck training, so this is unrelated to a tongue tie, right? So basic suck training really looks like, let's stimulate the back of the tongue. Babies have this magic suck button in the back of their mouth, most babies, the vast majority of them. When you put your finger up and you touch their soft palate, they have a reflex that causes them to kind of seal and start to suck. And so for most babies, it's easy to assess a suck. And what we do is we just have you you can use a finger. We have parents use a clean finger. I use a gloved finger. It's their baby. They do not have to put a glove on. And sometimes parents are cautious of that. So we'll actually even have them use a pacifier or a bottle. And what we're going to do with play a little tug of war, it depends on the baby. But babies learn so quickly. Think about, they go from fetuses to walking, talking human beings in 12 months. They are wired to learn. And so it's not so complicated with most babies who are just having tongue thrusty. And we basically have them push that tongue down, pull it forward, and then let them suck on their finger and kind of play a little tug of war. Those are the big ones that I see in the first 3 days if we have a baby who's not sucking well. Honestly, if they don't have a restriction, that's all it takes is teach them what they need to do, they do it. Restrictions are another, those babies need usually more. But even then, once we release a tongue, we do a lot of the same exercises. And these babies tend to learn, especially if we catch them early, quite quickly. They just are oh, when I do this, the food comes faster.
Right. Yeah. Well, and I think that's a great point. Paula saying, we do want to do those things prior to doing a release to see, is this something that the baby can just, again, learn and figure out without us having to go to the invasive of doing a laser. And I feel we really advocate for that for our parents, is that because some come in very hopeless and they're hoping that this is the magic wand. And I'm always this is not the magic wand, because honestly, just by giving the tongue mobility too doesn't always, there's 2 factors. There's the healing process after, which we've really talked about, but there's an importance of kind of what you do after you release that tongue to get the tissue to kind of heal now with more mobility. There's stretches that have to go along after the release. And then even after that, there is there's exercises that sometimes you have to do with the baby to really get them to realize oh, my tongue can move differently now. I'm not going to just continue to do it how I've been doing it before. And so we do, follow-ups with the patients and make sure that we check in on the wound healing and that those stretches have been being done appropriately after releases. And then they're going to get those similar type of exercises for afterwards, so that we really are kind of changing and improving the function of the way that they're using the tongue. And it's not just a I'm going to release the tongue because we see tension to it and you're off on your, way to figure it out. There's a reason that we do it, and we want it to be so that the baby actually kind of learns how to use the mechanics of having this new mobility to the tongue.
Also, teaching them before the baby is released. So if we have a baby who does need to be released, having parents get used to having their fingers in their mouth, their baby's mouth before we put a wound in there actually makes the post care so much easier for them, because they're not now trying to navigate, I haven't seen a single parent be like, yes, I put I let them laser my baby's tongue. They're terrified.
Yeah.
They just want it to work. So we need them to practice beforehand so that they're compliant with the exercises after. Because to me, if they're not going to follow through with the exercises, there's no point in going forward with their
100%. And we talk about that, when we go through the whole examination, and then talk about if even a release is an option or a possibility that they want to discuss before we even go there. I let them know what the post-operative care is going to look like, and make sure that parents have either already had some type of explanation on that, or that I go through that, thoroughly, because I think that is such an important component of it.
All right. So because we are short on time, I'm going to just do a couple of rapid fire things. I want to end, before we do the call to action, I want to end on the New York Times. What is it?
Yeah,
New York Times article. I think I know what that is. But one of the things that this is me being the dumb dad, right? The outsider of all of this stuff. I feel like when we did a Myofunctional series before, there was this whole thing about baby food and kind of how that's the devil, right? So do you mind talking a little bit about transitioning from, before we get there, I want to talk about breastfeeding versus bottle feeding, because bottle feeding is also the devil, apparently. So, but you guys have talked about that. So,
yes. Yeah.
And you guys talked about having pacifiers, which are also the devil. So, I mean, can you guys just kind of go into and demystify some of these things? I think that we have heard for all of these years.
Oh, I could talk about this. Yeah. This is 6 episodes, but let me try. So, artificial nipples are not the enemy, and they do not break babies. Babies do not get nipple confusion. That is not real. They are way too smart to get confused. They know exactly what they're doing. We kind of have dumbed down all this education around feeding babies, and basically are parents are too stupid to understand nuance, so we just have to tell them little bottles or pacifiers for 4 weeks. And I have been doing this for a long time, and I just so disagree. First of all, we have babies need to take bottles. In the United States, the vast majority of families have 2 working parents. They need that baby to take a bottle. Daycare is not going to cup feed your baby 4 ounces every 3 hours. That is not going to happen. So, and then pacifiers too. So I worked in a baby-friendly hospital where we're not supposed to give families pacifiers. I'm also a mom of 5. I had my 5th baby in a baby-friendly hospital. That baby was 2 hours old. I knew he was a pacifier baby. I was like, come right over here, nurse, and please get me a pacifier immediately. If you think about NICU babies, they are bottle fed. They have to be fed orally before they can leave. We have babies who are exclusively bottle fed 6, 7, 8 weeks. Guess what? They go back to breast with the right education. So bottles and pacifiers will not break a baby. I promise they won't break a baby. What you can't do is skip feeds with a pacifier. You have to make sure your baby's getting enough to eat in the first 2 weeks, because in the first 2 weeks, they will sometimes choose sleep over food. So pacifiers have to be used post-feed. They need to be getting regular weight checks, and we need to make sure that, they're eating as many times as they're supposed to, which is typically 8 to 12 times every 24 hours. So I think, we've put all these rules around. I'm a rule breaker. I
can tell that about you already, Paula.
When we talk about, and I know you, and correct me if you don't agree with me, but when we talk about it from bottle feeding too, is that, a lot of times when a baby is maybe tongue-tied or has some of these adaptions or compensations that have been kind of created, that there is more of a way to cheat that with bottles than there is by breastfeeding. And so that's why we think that the baby just prefers the bottle, is because they figured out this is they can share the system a little bit. It's easier for them, right? But that's where when I talk to parents and I say it, again, my preference is not whether you choose to do breast or bottle. And my hope is that you can actually do both, so that, like Paula's saying, these moms that have to get back to work at 6 weeks and they need to, be able to do both. but it's how the baby is actually feeding from the bottle that matters. Like, because again, there can be compensations. If you're having to tip that bottle vertical to literally like drop it into the baby's mouth, so it's just gravity and what's dripping to the back of the throat so that the baby can then swallow to get the milk, that's not truly feeding and using the mechanics of the tongue to actually be feeding correctly. So and this is not my specialty. So I always say, I'm like, this is not my specialty, but this is where even if you're choosing to bottle feed, going and working with a lactation so you can actually kind of learn again how we want that nipple to be placed into the mouth and how we want the, tongue to be able to move and engage that suck swallow ratio to be correct. That's so important.
I have a quick question. Just kind of coming as a myofunctional therapist, I think this would be a great way to kind of explain, because, one of the goals of myofunctional therapy is to have the tongue up to the roof of the mouth all day and all night. So what would you say, Paula or Leslie, whoever wants to take this question about, are we concerned that that pacifier is taking that place and the tongue's not going to, naturally go up there? That's a good one.
Yeah, what I think about that, so babies only have that really, really strong suck drive from till about like 4 to 6 months of life. After that, the pacifiers are our problem. And I have 5 kids. I've had children who wouldn't take a pacifier, and I've had ones that I've had to forcefully take it away with the binky fairy at 2.5 years old. And a couple things I will say is that if we lose the pacifier between 4 and 6 months, they have no problem getting rid of it. And they're not going to have it in their mouth all the time, right? So even with you may know that the SIDS guidelines to reduce the risk of SIDS, one of the best tools we can use is a pacifier when they fall asleep. Those guidelines only indicate that the baby has to fall asleep initially the first time with that passy in their mouth. They do not have to sleep all night with a pacifier. That's not the requirement to reduce the risk. So it's just that babies have this really incredible strong suck drive for 4 to 6 months. And that's when that pacifier is really useful, especially with a family who's experiencing pain at breast or has multiples. Like, babies want to suck all the time. I've seen families try to use their finger and then they're like, well, I had to sit like this for 5 hours. So my baby would sleep. And I'm like, right, well, actually you could give them a pacifier and it does it for you. So those are, I think there's a lot of misunderstanding around all of those pieces of like sleep and pacifier use and feeding. And like, we don't educate families. They're not taught any of this for sure. And usually the passy stuck way up and their tongue is holding it up against the roof of their mouth too. So not as bad.
Well, and part of it, even after like if a release procedure is done, sometimes that pacifier is helping that tongue continue to move. So it's actually helping us a little bit with the healing process and that engaging more of that correct swallow. And so I'll have parents, like Paula was saying, when we work on the tug of war exercise, actually use a pacifier to do that. And so it's the same thing. It's really it's important in those first 4 to 6 months of a baby's life. And then after that, we don't want this baby to be one that's just all day long pacifiers in the mouth, because that is completely training the tongue to do the opposite of what we want it to do. The tongue's now down on the floor of the mouth and the pacifier is taking up the space on the roof of the mouth. So if it's just used to fall asleep and soothe, and again, being realistic for parents, and you can't just say, don't use a pacifier, you have to, there's points where they need to use that pacifier, but then there's points where we need to be transitioning out of not using that pacifier and making sure that we're correcting for after the baby's fallen asleep. Are the lips closed? If you actually pull down that lower lip, are you seeing that the tongue is creating that suction up to the roof of the mouth? And those are important things for parents to be educated on and continue to be looking at, whether a baby had a release or not, but with pacifier use and non-pacifier use.
I'll add something else too. If you have a baby who absolutely cannot get that pacifier away from them, if they will not sleep, they're over 6 months old, you cannot get them to settle, it's a reason to actually see a myofunctional therapist, because sometimes it's airway preservation. They're using the pacifier to keep their tongue out of their throat, essentially, out of that mouth. Sucking too, right? Like they will hold on to that no matter what, because they're preserving their airway. It's the only thing they have to keep them, being able to breathe that way.
This stuff gets me really fired up, because I think this is why this is so important. Like, if you're a dental hygienist, we specialize from the neck up. We work in the mouth all day and all night. You know what I mean? We know the tongue inside and out. I was a class 4 tongue tie and I had no idea. I had good range of motion. I was a severe grinder, you know what I mean? But if you're not trained to know what to look for, and it's the same thing, I think this is why education is so important. Everyone, every pediatrician, everyone that works with babies, every parent should have access to, this knowledge, and I don't know, I think this is why it's so important to collaborate with, people who are specialists in their field. And that's why I appreciate Leslie and listening to Paula, talk about this, because even as a myofunctional therapist, this is not my specialty. And, I think that's one thing to kind of really hit home with is that, there's specialty to specialties and we need the right people on our team helping, because it's all about collaboration. It's helping the patient, helping the baby.
Yeah. Sometimes we work with a pediatric physical therapist. We work with pediatric occupational therapists because tongue ties can actually lead to things like torticollis, which is a twist, or plagiocephaly, which is like a flat spot. So there's so many pieces and so many different professions that should all be working together. Here, we actually get to see babies with our physical therapist. So we'll do our appointment jointly, which is magical. Be real cool if we had a myofunctional therapist.
I saw some winking going on the camera.
Mm-hmm.
Look, I think we left a few topics on the table. Unfortunately, we are out of time. But Paula, thank you, by the way, for being here. This was phenomenal to have you on. What we were talking about before is, you can help people kind of via Zoom, kind of everywhere. So if someone wanted to reach out to you, what's the best way for them to reach out to you?
Yeah, absolutely. So we do telehealth visits across the country, and our website is mainmother.com. It's MAINE, as in the state, mother.com.
And Leslie, you guys have a similar thing. You guys help so many people. Can you guys let us know what you have going on, what people can go and check out?
Yeah, obviously right now, same thing. When I see these babies, I'm seeing them in person and, working in a dental office doing that, but with Heidi and I and, our Myo2 Health company. And what our goal is with a lot of this too is to create access for mothers that are all over this country too. And so just releasing some courses and some different educational platforms so that moms have more resources to go to learn more onto this topic, and being able to connect them with providers that are in their area so that they can get the proper assessment and, see the correct team, so that they're not feeling alone and struggling, I think is, what I would love to see happen.
Yeah, so pretty soon we're going to have our website up and a landing page to give more information about that. So it's www.myo2health.com. And they can always reach out to us at info@myo2health.com or Heidi or Leslie at myo2health.com.
Awesome. Well, thank you so much for being here. I appreciate it so much. And this was so good. We had to make it a two-parter. I'm very excited about that. So thanks again.
Thank you, Andrew.
Thank you so much.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.